Now we're going to switch gears completely to a new topic, which is qualitative research in urologic congenitalism. And I'd like to welcome Dr. Kelly Harris. She's an assistant professor in the Division of Urology within the Department of Surgery, and she joined the faculty in July of 2024. She went to Washington and Lee University before she went to Johns Hopkins, where she completed her MD degree. And then she did an internship in residency in urology there before she came to Denver to do a fellowship at Children's Hospital, Colorado. She's already had a very productive beginning to her academic career with 43 publications and 3 book chapters. Welcome.
All right. Thank you all for having me. And at risk of sounding too self-deprecating to start, I do recognize that qualitative research and urologic congenitalism probably aren't top of mind for most people in this room. But these are two things that kind of get me up and going in the morning. At the very least, I'm going to share some quotes from some studies that we've done. So hopefully they provide some meaning to you all and give you some kind of insight as to why I think this stuff is important. So we're going to start with just some qualitative methods overview, and then we'll move towards what congenitalism is specifically within urology. And then I'm going to go through some examples of qual research within my field. So we as qualitative researchers, we look at things in their natural settings and we try to make sense of or interpret phenomena specifically in terms of meaning that people bring to them. So very different than kind of the quantitative research that we're more used to within surgery. So we describe routine and problematic moments and meanings in individuals' lives. Again, there's this very specific component to qualitative research that's about meaning and experience. It's not about data and numbers necessarily, but the data are the words, right, that people say. So within qualitative work, truth is constructed, right, by the people that experience reality. We don't control for variables, and in fact, contextual differences is actually very embraced, and we tend to downplay generalization, again, which is kind of the complete opposite of what you would see in quantitative research. I find that qualitative work is very useful when we want to understand how people interpret and draw meaning from their lives and their worldview and their experiences, and when we want to try to make sense of context in which things occur. It's not good if you want to compare groups like our previous presentation showed, but it's also not great for highly generalizable results as well. So I put this slide up here not for everybody to actually be able to read all of this, but just to show you that similar to quantitative work, we do have a very rigorous methodology guideline through which we need to conduct our research. So anytime I'm starting a qualitative study, I usually go through this, right, make sure that when I'm presenting my results that it all includes all of these. And as we're going through the study that we're addressing, right, all of these methodological issues that can come up. And the next couple of slides will go through each of these domains in a little bit more detail. So the first is really thinking about who is the research team, right? Because again, opposed to quantitative research, the researchers within qualitative work, we're not, just observers, right? We are a part of the research process, right? Our words and the way that we pose questions to individuals, who we are, the way that we are seen by the participants matters, right? And it affects what they're going to say. So again, we're not natural observers. We are part of the research process and findings as well. So when we're presenting our data, right, we want to make sure that we mention who the interviewers are, who the research team is, who's doing the coding. Did we disclose this, right, to the participants, things of that nature. And I think it's really, really important to note that just like in all areas of science, right, this is not something that one can do individually. You have to work in teams to do this. And it's very, very ideal if you're able to do it in a multidisciplinary way. So not just all surgeons, not just all psychologists or PhDs, but a group of individuals. So there are many different study designs or frameworks within qualitative methodology. This is a table from a journal of pediatric urology that goes through a couple of different studies within qualitative work that have been published within peds urology. And I just want to highlight, right, that again, that we don't need to go through all of these necessarily, but that there are these theoretical frameworks, right, that guide the way that we pose questions, the way that we create a hypothesis. And again, that kind of guides the overall themes and findings of the study. The two most common would be grounded theory and phenomenology. Grounded theory is when you're trying to kind of essentially create a theory or a hypothesis for why something is happening. And phenomenology is much more kind of hypothesis generating in nature, and again, just seeks to understand or again, understand experience. There are many, many different ways, right, that we can gather our data within Qual. The two most common would certainly be one-on-one interviews and then focus groups. And you would choose one or the other, right, based on kind of the nature of your question. For example, right, we'll see that many of the studies that I'm presenting are about sexual function. So many of them tended to be one-on-one interviews to maintain patient privacy and to allow them to feel more comfortable sharing. We create interview guides before participating in these interviews or focus groups, and they tend to be what we call semi-structured. So they're not like completely open-ended where you just let people talk, but they're also not, you know, where we have these very closed-ended questions and kind of steer, right, answers one way or another. We also take field notes and memos. Field notes are, it's usually a person who's not performing the interview or focus group, but it's somebody that's observing and can take notes on participant body language, the way that participants interact with either the interviewer or others if it's in a focus group. And then memos are things that we'll do after the focus group or interview to kind of reflect on our own experience within the interview so that we can reflect on our own biases and our own kind of thoughts and feelings about how everything went. And I just want to bring up this concept of saturation also, because I think something that comes up very, very frequently when people criticize qualitative work is that there's, you know, low numbers of interviews that we do. How do you know that you've kind of gathered enough information to make any conclusions or thematic analysis? And so we use this concept of saturation to do this. So I think of it kind of as a Goldilocks principle, right? You don't want to have too few interviews or focus groups so that you're missing a lot of really rich data and kind of common shared experiences. But you also don't want to have too much where you're drowning in words, right? And there's just too much to really make sense of. So we tend to think that the quality, right, of the interviewer focus group is much more important than the quantity of them. And we will continue doing focus groups or interviews until no new concepts or no new codes, which we'll get to in a second, have arisen. So there's a lot of it. This is a very iterative process. There's a lot of team meetings that occur throughout the interview process, and then certainly throughout this next process of going through the analysis and our study findings. So again, the data within qualitative work are words and quotes, right? There's no numbers. It's just all about what people said. So our data set, again, are these transcripts that we have from our interviews and focus groups. So we take the words and we go through and we code them, usually using some type of analysis software. But again, it's not like putting your data through, right, a statistical software. We put the transcripts in and then we create the codes as the research team. So we code based on either codes that we've created deductively, so beforehand, or that we've created inductively at the time of going through the interviews and the transcripts. From those codes, we're able to kind of sort things out a little bit more and create some types of themes, and then an overall big concept, kind of big picture. So I like to think of it as kind of this like, you know, spiral iterative process, right? Where we start with quite a bit of just words and data, and then through coding, through many, many, many team meetings, we're able to kind of get things and really condense down what people said into a common group of themes. Again, the analysis is always done as a group. One person trying to do this is not scientifically sound. And then I put in this note just to remind myself to mention to you all about member checking. So this is a really critical part of qualitative work, right? Where we as the research team, we go through what has been said, we try to distill it down into common themes, but then we always go back and present what we heard to the participants, right? Because if what we heard is different than what they were trying to say, that's very important for us to know. So we usually present our findings to the interview or to the participants. They're able to give us feedback, and then often from that, there's some tweaking, right, of the final themes before publication that we can do. All right, so switching gears, we're going to talk about one of my clinical loves, which is urologic congenitalism. So this is the diagnosis, management, and very importantly, the lifelong care of birth-related GU anomalies. We have a very, very strong emphasis on the importance of transitional care, right? So how do we take a child or an infant or a child who's born with a congenital anomaly and get them successfully through adolescence and young adulthood into a more like adult-centered model of care. These are just some examples of the many, many things that we take care of on a daily basis as pediatric urologists. But as you'll see, many, if not all of them, have long-term effects, right? So long-term effects on the kidneys, on the bladder. Oftentimes these patients may have an increased malignancy risk, and certainly all of them you'll see in this table have long-term influences on sexual and reproductive function. So historically, many kids who were born with GU anomalies unfortunately died very young. Kids with spina bifida, very few survived infancy. Within exstrophy, and specifically cloacal exstrophy, right? The first documented survivor of cloacal exstrophy wasn't until the 1960s. And boys with valves, many of them died before adulthood, specifically those who needed renal replacement therapy and kidney transplant. In the second half of the 20th century, there's been this boom in increased survival rates for these children. And so this has led to a need for an interest in care for this population, and how do we take care of them, not just when they're young, right, but when they become adults and are ready to have children of their own. As you can imagine though, right, there are many, many challenges to how we study this population, but truly study it well. If we're trying to, study people from when they're born until again, when they're having kids of their own or dying, right, there's a very, very significant time, resource, financial need to have true prospective or longitudinal studies. One other challenge we run into is we easily lose patients to follow-up, which is actually kind of a good thing, right? These patients can often be thriving, have very, very full lives, move away from home, go to college, which again is a beautiful thing, but we can lose them. There have also been very significant changes in management strategies over time. And I think, girls and women with cloaca is the perfect example of this, right? The way that when these girls were born in the 60s and 70s, the way that we reconstruct them is completely different, right, to the way that we manage them now. And so studying, right, women who are in their 60s and 70s is very different than studying women in their 20s and 30s today. And importantly, right, there's a very wide variation in who these people are, right? Many of these are rare disorders. There's very patient-specific types of nuances to their anatomy. And so every patient is unique in many ways, which is, I think, one of the reasons why those of us who take care of them love taking care of them, but it can make it very difficult to actually study in a quantitative way. So for all of these reasons, right, I find that qualitative research is actually one of the best ways to empirically study these populations. All right, so we'll move on to a couple of examples. And the ones that I'm presenting that aren't from our group are specifically in spina bifida. And then the one that I'll be presenting from our group are in women with anorectal anomalies. So male sexual function in spina bifida. So this is a study out of a group in Chicago. And their goal was to evaluate the applicability of the IIEF. So those of you who are not urologists in the room, the IIEF is one of the ways that we measure male sexual function. It's specifically asking about erectile function in partnered experiences. So they really wanted to know, is the IIEF applicable to men with spina bifida? If it's not, what suggestions would they make? So there were 20 participants, so they did 20 individual interviews. They had the men complete the IIEF, and then they basically had, again, a semi-structured interview about it, right? And what parts of the IIEF were relevant, what were irrelevant, and again, what would they suggest, right, for a different health measure, a sexual function measure for these men. So some of the things that men noted that were not captured by the IIEF were lack of control over sexual function that they felt as men with spina bifida, poor lower body sensation, right, that can be experienced. Certainly the role of urinary incontinence in sexual experiences is not captured at all, right, by this erectile function questionnaire. The fact that there are some spina bifida specific physical limitations, and then psychosocial barriers to sexual activity. And then some of the suggestions that they made, which would be helpful to include in like a spina bifida specific sex questionnaire, would be to include questions focused on non-partnered sexual activity. Again, the IAEF only asks about activity with a partner. They recommended to expand the time frame. This questionnaire only asks for the past 4 weeks, and they suggested making it quite a bit longer than that. And then to include specific questions about some unique ways that people with spina bifida might experience sex. So this next one is the same study group, and it's actually the same interviews from the same group of men. So this is something that's often done in qualitative work, is if the data is so robust to kind of narrow things down into individual studies. So this one was looking more specifically at fertility potential and future parenthood in men with spina bifida. So again, the same 20 participants. None of these men had actually fathered a children, but many of them desired future fertility. And this is one of the ways that the authors presented their work, was looking at barriers with the perspectives and then facilitators. And then within that, there were elements of uncertainty and concerns. So I know it's a little bit difficult to read, and that's okay. We have some more quotes coming up that are much more easy to read. But again, I think if you are reading any qualitative work or listening to any qualitative presentations, again, the quotes are really what kind of stand out. The quotes can be very important for advocacy work, right? They're very important to just really hear what people are saying more than just what the analysis of the themes are. So some of the barriers, though, that men noted were uncertainty around their fertility potential, also the uncertainty around whether spina bifida was hereditary. Some of the concerns that were raised were about being a parent and raising a child potentially with spina bifida. The concerns about being a parent, they kind of divided into kind of just general concerns that we all might have about becoming a parent, and then specific concerns about being a parent or a dad with a physical disability and having a child. And then the facilitators that they noted were gaining knowledge on fertility testing options, how to prevent neural tube defects with folate supplementation, and then they really emphasized the strong importance of peer and family support to help overcome a lot of these concerns. And then for female sexual function, there's been another group that's really focused on female sexual function in patients with spina bifida, but also just disabilities in general. So these are more kind of phenomenological in their methodology. This study was looking to really just understand what women know about their sexual health and their experiences with sexuality. So I'm not going to go through all of the themes because they had many, many themes for this, but I just wanted to kind of put this one table up just to kind of show you their process of how they went from, again, these bigger open-ended codes, right? Pediatrician did not talk to her about sex, dated 2 men who did not view her as sexual, felt that doctors didn't view her as someone interested in sex. And then they were able to kind of parse everything down to this one, again, more kind of common theme that a lot of women with spina bifida feel that they are perceived of as asexual by partners, by their medical team. I do want to mention, just so that we all know, right, one of the conclusions of this study was this perception of being asexual. Women felt that that put them at higher risk of sexual assault. And we do know that women with spina bifida are at significantly higher risk of sexual assault and sexual violence. So right? This study just kind of corroborated that, but it used, again, what the actual patients were saying as opposed to just asking the question, you know, have you ever experienced sexual assault? All right, and this last one that we'll talk about with spina bifida, again, this is about women's experiences with fertility and reproductive health. And this is a table that's kind of showing some of the unanswered questions, right, that many of these participants, which you can see, still had. So they still had questions about how am I different, right, from other girls, from what I learned in school. You know, if you see how many participants, right, asked, can I get pregnant? In this cohort, there were 5 women that had unintended pregnancies. If I get pregnant, what would happen? Can I physically carry a child? Right, so the kind of the conclusions from this study were that women with spina bifida do have a very poor understanding of their reproductive health potential. And again, many of them had unintended pregnancies. So it's kind of this call for us as urologists, as healthcare providers for these women with spina bifida to really engage in strong healthcare, strong sexual health education to let them know they can get pregnant and what to do if and when they do get pregnant. All right, so we'll take the last, hopefully less than 5 minutes to just talk about one of the studies that we have ongoing here. So sadly, almost 95% of patients, men and women with anorectal anomalies, say that they have never received any support for sexual issues. We know from some of the quantitative data that our group has done that women with anorectal anomalies have much lower female sexual function scores than what the kind of clinical cutoff would be. And women with cloaca, unsurprisingly, have worse sexual function compared to those with other types. So to explore this a little bit more, like why is this happening, basically, we performed semi-structured interviews with 18 women. And these 3 questions were kind of the crux of our interview guide. So what were your first memories regarding sex? How do you think your condition and the surgeries you've had have affected you? And what questions are important for us to ask to screen for challenges? So these are just our preliminary themes, right? So where our group is right now is we have completed our coding. We have met many, many times to kind of try to distill some of the codes down, again, into smaller and smaller, more robust themes. We have not done member checking yet, and we're still tweaking with these, but I just wanted to present to you some of our initial findings and also, again, to really realize some of the quotes that were said to end with that. So what we believe is that women with anorectal anomalies have very varied experiences, both positive and negative. Some seem to be very disease specific, and some are probably just universal to many, many women. Within this, there are a couple of sub-themes. So there was a very strong impact of bowel function, concern about bowel incontinence, bowel management on themselves as sexual people, the importance of connection to others with anorectal anomalies, significant concerns about the way that their genitals looked and about pain that was experienced with sex. And then there was a very strong component of the influence of external factors such as their family and medical trauma. So I just want to leave some of these quotes up here for you all to just very quickly read. Again, these are some very key quotes about the impact of bowel function on themselves as sexual people. Some quotes about the importance of connection to others. Concerns about appearance and pain. And then finally, from the external influences, the top 2, one is a little bit more negative, one is quite positive. And then this last one really speaks to some of the medical trauma that these women experience. So again, we're still working with these. We certainly haven't presented any of these to the participants. But these were some of the very kind of critical things that essentially came through in every single interview, that was conducted. And again, I think one of our major conclusions from this is that treat the patient, not the disease, is a common trope that we all hear. But I think specifically in this instance, we do need to consider the disease and its impact. And our hope is to be able to use some of these findings to help create, again, more disease-specific sex health screeners for women with anorectal anomalies. So in summary, qualitative research is a scientific process. It requires expertise in team science. In my opinion, congenitalism is a field of medicine that is perfect for this type of research because there are very, very rich patient stories and experiences, but very little empiric data that we have even access to. And again, utilizing qual, I think, is an excellent opportunity to advance our understanding and care for this population. All right, so thank you, and I'll take any questions.
So if no one from the audience has one, this is a method of research that I think most of us have little to no experience with. So how did you start your career using that methodology? Who were the collaborators? Who were the people who worked with this? As opposed to science, no, it's a team effort. So how did you start?
How did I find this? I think a lot of us within urology consider ourselves to be uropsychologists. And I think particularly those of us who have an interest in sexual health recognize that, again, I think many of us in the room would note that, a male sexual function questionnaire that only focuses on erectile function probably isn't the best way to capture, the entire experience. And so I've always felt that way about a lot of kind of, validated surveys, quantitative work that I've seen, and again, particularly in this population. So when I came here, I had an interest in pursuing qualitative work, and we're very lucky to have a psychologist that works on staff specifically with our urology patients who has a lot of experience in qual. So again, speaking to the team science nature of this, of if you, see a gap in research, have somebody that's kind of, is easy to work with and at your disposal who has that expertise, that you can learn something like this in a pretty quick period of time.
Yeah. As I listen to people presenting grant rounds that are in specialties other than one time, I think of how their work applies to what I do. And as I was listening to you, I think colorectal surgery, IVD, lots of ileostomies, colostomies, and those sorts of things. And I would guess that the type of research done, pure population, very specialty probably. It's 8 o'clock, so let's call it in your grand rounds and let everybody get to work. Thanks very much.